Hello and welcome to this podcast on gastroenteritis and dehydration. So we're going to talk about the definitions of gastroenteritis, the etiology, clinical features, doing a clinical assessment on a child that has gastroenteritis, discuss the management, including the treatment of dehydration, and the prognosis. So is this an important topic to learn about? Well, yes, very. Gastroenteritis is the leading cause of death in the developing world, killing over 4 million children a year worldwide. It's also the second commonest cause of primary care consultations after the common cold, so you definitely will be coming into contact with it. So just going through definitions. So gastroenteritis is the inflammation of the stomach and intestine, and it's usually due to an infective agent. In young children, it's characterised by sudden onset of diarrhoea with or without vomiting. So the enteric virus is the usual cause of gastroenteritis, but it's also caused by bacterial or protozoal infections. Bacterial gastroenteritis presents differently from viral, so it's useful to think about them in two classifications. So the main viral cause is rotavirus, and about 60% of cases that you see will be caused by rotavirus. There's also enteric adenoviruses and Norwalk agents, as well as lots of others like astrovirus. It's important to think of the viral causes against the bacterial because they do present slightly differently. Bacterial causes are such as Salmonella, Campylobacter, Shigella, and E. coli. All of both viral and bacteria can affect children at any age, but bacterial do commonly occur in children less than 2 years old. They both transmit through the fecal-oral route, but also bacterial can be caught from poorly prepared meat. They present slightly differently. The common features that they both cause diarrhoea and vomiting. They both cause crampy abdominal pain, fever and dehydration, and disturbances in electrolytes. But the differences are that bacteria causes dysentery, so blood or mucus in the diarrhoea, malaise and tenesmus, and viral causes upper respiratory tract infection signs, which is particularly prevalent in the rotavirus infection, and the diarrhoea tends to be more watery without the blood or mucus. It's really important to remember in paediatrics that a number of disorders in children can masquerade as gastroenteritis. For example, meningitis or septicemia or DKA and lots of surgical disorders can also cause diarrhoea and vomiting. If in doubt, definitely admit the patient. So we'll go on to assessing the child clinically. So assessing dehydration is really important in paediatrics, as it can quickly lead to shock, severe metabolic acidosis, and even death in children. So in your history, it's important to ask whether the child appears unwell, has an altered responsiveness, i.e. if they're irritable or lethargic, has a decreased urine output, so you could ask about the number of nappy changes in that day, or whether they have pale or mottled skin, or whether they're feeling cold. So this table is pretty important because paediatricians like to classify dehydration as either mild, moderate or severe, and then they tend to refer to the level of dehydration in percentages. So mild would be 0 to 5% dehydrated, moderate 5 to 10%, or severe 10 to 15%. Now the way you determine how dehydrated the child is through looking at a series of signs. Got them all listed here, but most of them you can do just through observing the child. For example, you can look at their mucous membranes, their colour, their level of consciousness, and also just having a look at some of the things that you do with adults, the heart rate, the blood pressure, and the skin turgor. What's particularly important in children is to consider their capillary refill and also to weigh them, as it can be a very sensitive marker to their level of dehydration. The blood pressure is also important, as like adults, it only really becomes decreased in severe dehydration. So what about investigations? So Ed likes to lay out his investigations in this table, so I've done that just to please him. Firstly, taking blood cultures and stool cultures. To be honest, blood cultures are only really done if antibiotics are going to be used in the child. And stool cultures should only really be done if they've had a recent travel history, if they've had more than 7 days of diarrhea, if there's any uncertainty about the diagnosis, or if there's suspected septicemia or dysentery, or of course if a child is immunocompromised. Basic blood tests are important, to do a full blood count, use these particularly to look at the level of dehydration, CRP, and of course glucose. If the child does develop colitis, then you can do a sigmoidoscopy, although this is pretty rare. So the management. The principles of management are basically supportive. So you're going to rehydrate the child. Primary prevention is also really important. You want to encourage fluids or milk, and you can also use rehydration salts, such as diaurolite. You have to remember that antibiotics are rarely needed, so don't start prescribing ceftriaxone for every child with gastroenteritis. So treating dehydration. And this is where that table comes important, when you've classified whether the child is mild or moderately or severely dehydrated, because there's different management for each category. If they're mildly dehydrated, then you just need to substitute normal feeds with the oral rehydration fluid until their diarrhea or vomiting subsides. For moderate, they tend to do a 6-hour trial of oral or NG feeds, aiming for about 100 mils per kilogram. And this can happen in A&E while the child is being observed. And then they move to IV fluids if the child doesn't respond to this challenge. For severe dehydration, you always give the child IV fluids. You always start with a bolus of normal saline if they're severely dehydrated, and it's about 20 mils per kilogram. If there's no response in the child after this, then you can repeat the bolus until there is an improvement. So when IV fluids are required, you need to get your calculator out because it's quite complicated in paediatrics. But I'm going to break it down into 5 stages to make it slightly easier. Firstly, you have to calculate the fluid deficit, then calculate the maintenance fluid of the child, and then work out the rate of fluid that you're going to prescribe and which fluid to prescribe, and then you obviously monitor and reassess. So firstly, calculate the fluid deficit. So the fluid deficit in mils is the percentage of dehydration times the weight in kilograms times 10. So again, that table is really important to calculate the percentage that the child is dehydrated. Then you need to calculate the maintenance fluid over 24 hours. Now, this is slightly complex, but if you just take it simply, for every kilogram up to 10 kilograms, you prescribe 100 mils per kilogram per day. Then for every kilogram between the weight of 10 to 20 kilograms, it's 50 mils per kilogram per day. Then if the child weighs above 20 kilograms, for every kilogram you give 20 mils per kilogram per day. Simple. Now you need to calculate the fluid rate. So the hourly rate is the 24-hour maintenance fluids that you just calculated, plus the deficit that we did in the first stage, and then you minus any boluses that were given, and that's usually an A&E. Then you divide it by 24, which gives you the hourly rate. It's then important to prescribe the appropriate fluids. If the child is hypernatremic, then it's really important to correct the sodium slowly. So the fluids are usually given over 48 hours rather than 24. But normally the child will be normo or hyponatremic, and in these cases you use isotonic solutions. 0.9% saline with 5% dextrose is commonly used in peds. Potassium also has to be considered, and in 24 hours, the child will need 1 to 2 millimoles per kilogram. So after doing all these complicated calculations, and you finally get your fluids up, you need to constantly monitor the child, especially if they're severely dehydrated. You look at their vital signs, their urine output, their weight, and their U's and E's. Usually, U's and E's are repeated every 6 to 12 hours in a child that's on IV fluids. You also have to look at any other losses, for example, how often they're opening their bowels and vomiting. And there's just a little table there with the normal urine outputs that you'd expect in newborn, toddlers and older children. So what's the prognosis of gastroenteritis? Viral gastroenteritis usually lasts less than 7 days, except enteric adenovirus, where diarrhea can last over 14 days. And in viral gastroenteritis, a child can also develop temporary lactose intolerance. Bacterial gastroenteritis has lots of complications. For example, bacteremia, secondary infections, Reiter's syndrome, HUS, particularly with E. coli, reactive arthropathy and colitis. So, just to summarise what I've been through, discuss the etiology, the clinical features of gastroenteritis, how to assess and treat dehydration depending on a child's fluid state, and always remember that other conditions may masquerade as gastroenteritis. Thanks for listening. See you soon.